So picking back up here to look at some differences with the pediatric body, the integumentary system is going to differ in a couple of different ways. The skin is going to be a little bit thinner, and also they have less subcutaneous fat, so they could tend to burn more deeply and easily with less exposure. So that's a concern for different types of burns. They also have a higher ratio of body surface area to body mass, which can lead to larger fluid and heat loss when we're thinking about environmental emergencies or things like those burns, where we're thinking about body surface area in relation to injuries. So looking at the scene size up, the assessment begins at the time of dispatch. So we want to prepare mentally for approaching and treating an infant and child. Sometimes this can be kind of a nerve-wracking for some providers. They don't like pediatric assessments, but trust and believe that it can, again, be very rewarding, and it doesn't have to be scary. You just got to stay calm and know what you're looking for. So plan for your pediatric size up, your equipment, and age-appropriate physical assessment. We want to collect the age and gender of the child, the location of the scene, and the nature of illness, mechanism of injury, achieve complaint from dispatch if possible, or once we arrive on scene, get it from our patient or our family members, bystanders, whoever is there. Just like with our general impression, as we're getting there, we're starting to note the position in which the patient is found. They may have a safety threat if they have some type of infectious disease. So again, making sure that you're protected with your proper PPE. Also looking at the environment. A traumatic scene where the child is unresponsive or too young to communicate can be kind of scary. We want to assume the injury was significant enough to cause head or neck injuries that would cause them to become unresponsive and maintain that C-spine. Now, this is very important. The pediatric assessment triangle you will see in multiple test questions. So I would encourage you to make some notes on this and remember what it is and what it's used for. So this is a tool that can be used in the primary assessment to determine if the patient is sick or not sick, or rather critical or not critical. And it should be able to be performed in less than 30 seconds. And it takes a look at these three things, and that's appearance, so overall appearance, their work of breathing, and circulation to the skin. So looking at the skin color, temperature, and conditions. So those three things we can determine pretty quickly to determine are they sick or not sick. From these findings, you will decide if the patient is stable or if they require urgent care. If they're unstable, we're going to move on to assessing ABCs, treating life threats, and immediate transport. If they're stable, then we're going to move on with the remainder of our assessment process like we normally would. For pediatric patients, you need to do hands-on ABC, so looking at the airway physically, listening and feeling for breathing, comparing our pulses, touching that skin color, temperature, and condition, getting all of that stuff hands-on. So looking at the airway, if it's open and will remain open, move on to assessing the respiratory adequacy. If the patient is unresponsive or has difficulty keeping their airway open, then we're trying to look and see is there anything there that needs to be suctioned or removed, like mucus, vomit, blood, or foreign bodies. We want to try to place the patient's head in that neutral sniffing position, and remember we can pad underneath the neck if we need to help stabilize that. We want to establish whether patients can maintain their own airway, and if they can't, then we want to go ahead and intervene using some type of manual airway maneuver, possibly an adjunct, and maybe BVM ventilations. Looking at the breathing, we're going to look, listen, and feel. Remember that technique that we talked about from CPR. And we're going to place both hands on the patient's chest to feel for the rise and fall of the chest wall, that butterfly technique that I demonstrated for you so that you can see if the hands are rising equally or if there's any issues with that. Belly breathing in infants is considered adequate. They are traditionally belly breathers, so seeing movement of the abdomen and not the chest is okay for them. With bradypnea, remember that's a slower than normal rate of breathing. This is an ominous sign and indicates impending respiratory arrest. Something that we're going to look at here in this PowerPoint is how respiratory issues are usually the leading cause of cardiac arrest for a pediatric patient, unless they had some type of already predisposed underlying condition related to their heart or something else, then 9 times out of 10 it will be related to respiratory issues, whether that's swelling, whether it's respiratory drive issues, whatever it is, could be an issue that are leading to the cardiac arrest. So looking at circulation, we want to determine if the patient has a pulse, if they're bleeding, or if they're potentially in shock. If this is an infant, we're going to palpate the brachial or the femoral pulse. If they're older than that, we can check the radial and the carotid as well. So strong central pulses usually indicate that the child is not hypotensive, but weak or absent peripheral pulses can indicate decreased perfusion. So remember, for the adult patient, the presence of a distal pulse could indicate that the blood pressure was between 80 or 90 systolic. That's not necessarily the case for children because everybody's normal blood pressure is going to differ. Usually a rule of thumb, if you remember back to vital signs, is 70 plus 2 times the patient's age. So if they were 10 years old, then that would be a normal systolic blood pressure of 90. Tachycardia can be an early sign of hypoxia, so keep that in mind as well, that the body, in an effort to keep everything the same and maintain homeostasis and compensate, is first going to try to speed that heart up. We want to interpret the pulse within the context of overall history, the pediatric assessment triangle, and the primary assessment, and put all of these things together to try to determine, are they stable or not stable. Again, looking at the skin and the cat refill, very important. We can look at the disability, which would be using the AVPU scale or the pediatric GCS scale. And the biggest difference between the pediatric and the adult GCS is that on the pediatric, instead of it asking, is the patient oriented in their speech or are they confused, it's going to say, are they crying or gurgling, making normal sounds, babbling, whatever it is, as opposed to not doing something that's normal for them. So we can also check for the pupils and check for symmetric movement of the extremities, so checking PMS to make sure that there's no disability with the neurologic system. That's what we're checking for here. And we're also going to ask about pain, as that would be related to the neurologic system. And then we want to expose the patient. So again, looking at hands-on assessment, if we need to remove clothing for observation. Remember, they might be more prone to hypothermic events, especially small infants that need to be kept warm, wrapped up in blankets, have an increased temperature in the ambulance, whatever the case may be. So to make our transport decision, again, we're going to decide whether this would be rapid transport, whether it's a load and go, or if it's a stay and play, and then where are we going to transport to. So know if you have specialty facilities like pediatric trauma centers nearby that you can openly transport to, or if you've got to have some type of special situation to go there, or can you transport to the hospital of the family's choice. So things that we want to consider rapid transport: if they have a significant mechanism of injury, a history compatible with serious illness, potentially serious anatomic abnormalities, any significant pain, or an abnormal level of consciousness. We also want to consider the type of problem that's going on. Would there be any benefit to calling for ALS to provide some treatment in the field? Also, your comfort level, like if this is a pretty serious situation and you're not going to be comfortable with it, then you might need to call for an additional provider. And also your transport time to the hospital. If the patient's condition is urgent, then initiate immediate transport to the closest appropriate facility. And appropriate being the key word here. If you know that you have a local facility that cannot handle pediatric patients, then we would want to encourage the patient or family to go somewhere where they can. If the child is less than 40 pounds and this is not a life-threatening situation, then we want to consider transporting them in a car seat. If it is a life threat and we need them to be on our stretcher so that we can openly work on them, then that's fine. But if not, and we need to be transporting them in a car seat. So you can secure that car seat into your captain's seat or onto the bench seat. In some cases to the stretcher as well, although I would recommend one of the other two during transport. And then you can move the whole car seat over to the stretcher to wheel them in, just for safety's sake. So follow those manufacturer's instructions to secure that car seat. If the patient does require spinal immobilization, then you're going to consider a couple of things here. If the child was already in their own car seat and it is not damaged, then you can consider that. But if the car seat was damaged in any way or they were ejected, then you don't want to use that car seat. So just kind of looking at the entire situation. You're also trying to determine what other supplies you might need. There are smaller pediatric backboards. There are small prepackaged pediatric immobilizers, which are very similar to KEDs in how they are packaged, usually stored in the same compartment in the ambulance. Ultimately, the goal is to secure and protect the pediatric patient for transport in the ambulance the best that we can. If you do transport the patient on a backboard, you might need to fill those gaps or voids with some type of padding, blanket rolls, towels, things like that. So when we're getting our history, it's going to depend on how old the patient is as to who is going to be giving you the information. If this is a small child, probably going to be coming from their caregiver or parent. But if they are school age, older school age, or adolescent, then they're probably going to be able to answer some of these questions for you. We can ask the questions to the parents or the child about any immediate illness or injury based off of their chief complaint, just to get their side of the story. So asking about the nature of illness, mechanism of injury, the length of the sickness or injury, any key events leading up to it, the presence of any fever, effects of the illness or injury on the behavior, their activity level, any recent eating, drinking, and urine output. And that's very important, especially for infants, that we ask about how many wet diapers they have had today, and is that normal for them, so that we can kind of judge for dehydration. Asking about the presence of any vomiting, diarrhea, abdominal pain, the presence of any rashes, obtaining the name and phone number of the caregiver if they're not able to come to the hospital with you. So generally, when if it's not an emergency, life-threatening situation, you would have one parent ride with you in the back of the ambulance. If it is a life-threatening situation, you might have them sit up in the front seat just to give you more room to work and not have them interfere. We want to get that sample history again the best that we can, and asking OPQRST questions the best that we can based off of their age and developmental stage, knowing that we might not have all of the answers to those things. Then we're going to move on to the secondary exam. So the physical exam of the entire body here, looking for DCAT BTLS, would be used the same way as it would for adults. Focused assessments will be performed on patients without life threats, so looking at medical assessments and focusing on their chief complaint. Infants, toddlers, and preschool age children should be assessed starting at the feet and ending at the head, unless it's a life threat and you need to start at the head, but otherwise try to start down at the feet. School age and adolescent can be done as normal from head to toe. Looking at vital signs, some guidelines and equipment used to assess the adult circulatory status have limitations for pediatric patients, and the normal heart rates will vary. So again, making sure that you have an appropriately sized equipment, appropriately sized blood pressure cuffs, that you have a pediatric SpO2, and that you remember what's normal for each age range. Usually we don't assess the blood pressures for children who are younger than 3 years old. It's just not going to give you an adequate reading, and so kind of don't need to do that. We will just take the pulse, checking it at that central site at the brachial artery. The assessment of skin is a better indication of the pediatric circulatory status, and so that's why looking at skin color, temperature, and condition, and capillary refill are so important for them. When equipment is used, again, very important that we're utilizing appropriately sized equipment for the patient and remembering what's normal. We said that the normal child blood pressure up to 10 years old would be 70 plus 2 times the patient's age in years to give you a normal systolic blood pressure, so that you can kind of gauge what is going on with the patient. Are they hypotensive or hypertensive based off of those findings? The respiratory rates can be difficult to interpret, especially if they're breathing really fast as a small infant. So count them for about 30 seconds instead of 15, and then double that number. In infants and those younger than 3 years, we want to evaluate respirations by assessing the rise and fall of the abdomen. We said belly breathing is pretty normal for them. We also want to assess the pulse rate for about a minute, noting quality and regularity. Sometimes it's normal for small children to have irregularities in their pulse, so that's okay. If they're not having any complaints related to that, I wouldn't worry too much about it. And then we can also evaluate the pupils and the pulse oximeter as well if the patient has any type of respiratory distress.